This week on the BackTable podcast.
Something that I, of course, would love to see is us figuring out how to sustainably build surgical oncology programs in urology in low middle income countries. I mean, I'm not a surgical oncologist, obviously, but it's a challenge. Patients and providers do want to be able to diagnose people early and treat them. And unfortunately, I don't think there's a lot of financial resources out there to work on building programs like that. But I'm hopeful that over the next 10 years, we can figure out how to screen for bladder cancer in low middle income countries that probably have much higher rates than we do.
Welcome to BackTable, everyone. This is George Koch from the Ohio State University, and I'm really excited to introduce Dr. Jane Kurtzman from the University of Utah today to discuss international service in urology. Dr. Kurtzman, can you start by telling us a little bit about yourself and how you got started working internationally?
Sure. Well, thanks so much for having me. I'm really excited to be here. I'm really honored that I got invited. So yeah, a little bit about me. So I'm currently an assistant professor of urology at the University of Utah. Finished my fellowship just recently this July in Reconstructive Urology at the U. Previously did my residency training at Columbia University in New York. And my interest in international work actually dates back to when I was in college. Between my freshman and sophomore year of college, I had the opportunity to go abroad and volunteer with a completely non-healthcare related NGO that was working in local communities in Kenya to build sustainable housing and sustainable schoolhouses. And they utilized sort of an international partnership model where they were primarily employing local construction workers and local people in delivering their, I don't know what I want to call it, but in delivering sort of their mission. So that was the first time I went abroad, and I had an experience living in a low middle income country, and I really felt like, wow, I'd really love to return to this environment in the future. And then right after I graduated from college, where I had studied anthropology, I got a job actually working at ABC News. And in ABC News, I got more and more interested in sort of public health awareness, et cetera, and sort of used that time there to segue into a job in international health. I was really fortunate. Some opportunities aligned themselves, and I was offered the opportunity to move to Cambodia and work for a USAID-funded health system strengthening program. And that was my first exposure to sort of global health work. I lived there for about 2 years. The project I worked on was a $40 million project that was implemented over 5 years. The primary goals of the project was to help the government build a free and subsidized public healthcare system for the poor and the very poor. And my primary role there was working with the Ministry of Health and primarily the Medical Council of Cambodia in building the first ever national registration system for doctors. And so after that experience, I said, this is something that I want to have be part of my life. I actually left Cambodia to apply to medical school, went back, got in, moved back to the States to go to medical school, and thought at the time I was going to become a double-boarded emergency medicine, internal medicine doctor, because I felt that was the path forward for being someone that did global health work. Quickly learned that was not my calling in medical school and that urology was. So I became a urologist and have, over the last couple of years, found my way back to global health work now in the world of global surgery. And I'm super excited to have found my way back.
Yeah. I mean, gotta be an amazing place to start it, like building the health system for a whole country for low income folks. That's like, you started at the top. That's awesome.
Well, I wasn't doing that. I was sort of low man on the totem pole. We had about, if I remember correctly, about 145 staff, primarily Cambodians who worked on the project. And my role was relatively minimal, but it really gave me the insight and opportunity to learn about how to work within local governments in low-income countries and sort of the role that they play in their healthcare systems, which is very different than the way we interact with our healthcare system here in the United States as physicians. So really gave me the opportunity to learn about how physicians, I should say, interact with the Ministry of Health, which is unique to countries outside of the United States.
Yeah. And what were your impressions of these experiences, like the way that they interact with the healthcare system?
Well, I think what I learned from it that I've utilized in sort of the work I'm now doing in global urology is that the Ministry of Health really determines how care is delivered in many of these countries and what type of surgical care surgeons can provide. They're very much at the center of all of healthcare delivery. So in the United States, maybe you want something from your hospital, you need a new instrument, or you want to hire a new subspecialty surgeon. That's generally a decision that's being made on the hospital level or at the School of Medicine level. But when you're working in countries that have different structures, that all really comes from the Minister of Health. And so having their input, their buy-in, their involvement in any type of capacity building, program development is really key to the success of that program because it really dictates how people practice medicine. And, it's just different. Probably one of the biggest differences compared to many high-income countries that are much bigger with much more kind of siloed healthcare systems.
Would you say that in low and middle income countries, that's more the model and the U.S. system is more high income? Or would you say that most international systems are more the model you're describing versus the U.S.? I know it's kind of parsing, but I'm just curious. I hadn't heard about it talk like this before.
Yeah, I'm not sure if I know as much about other high-income country systems and their, interactions with their, let's say, national health departments or equivalents of the ministries of health. So I can probably only speak to the countries that I've had experiences working in or knowing people who have worked in, which are primarily the sort of low and middle income countries. But I'm sure we'll get into this later when we talk about some of the programs that I've been involved in helping build. And the key to all of that has really been first gaining an understanding of how that healthcare system works before trying to, insert myself or any program that I'm involved with into their system, because you kind of have to understand the larger ecosystem in order for your work to be sustainable.
Yeah, absolutely. You kind of know what you're working with, essentially.
Yeah. Exactly. Yeah. And it's very easy to go abroad and just be like, well, they have doctors and they have patients and this looks like our hospital, maybe a little different. Resources are different, but they're kind of doing the same thing. So I'm just going to kind of propose they do the same thing there that we do here, but actually it's a completely different kind of structure that you are not privy to those first couple of times that maybe you go somewhere.
Yeah. As far as urologic disease, coming out of your work with the organizations you worked with in college before medical school, you thought emergency medicine and internal medicine might be the way to go. Now you're a urologist. Could you talk a little bit about the need for urologic care abroad and how you kind of informed working again in the international space now being a urologist, but with those experiences?
Yeah. Well, anybody that reads sort of global health literatures in the global surgery space knows or has probably come across the quote that 5 billion people lack access to surgical care and that 75% of surgery that's delivered happens for the 25% of patients that are living in higher income countries, that only something like 4 or 6% of surgeries actually occur in low and middle income countries. So, a huge number of patients and people across the globe that don't have equitable access to surgical services. When you think about or you learn about global health expenditures, the United States probably spends somewhere between $10 and $13 billion on global health related expenses a year, more during the COVID eras. But on average, somewhere like 10 to 13 billion. And very, very little of that money goes towards global surgery. I've seen statistics quote as little as 0.1% of all funds for global health go to global surgical causes. Urology in the world of global surgery has even less of a presence I was going to say that there was one paper that came out probably about 10 years ago that looked at all charitable organizations in global surgery across, I think it was the United States, United Kingdom, and New Zealand. And it was about $3.1 billion that had been spent annually on healthcare expenses related to global surgery programs. Granted, these were kind of private organizations and public organizations. And I think it was 0.14% of those expenses were for urology-related care. So very, very low financial attention to urology causes. So urology, I guess how your question is sort of burden of urologic disease. So not great numbers out there to quantify the burden of urologic disease. The WHO puts out, numbers about the global burden of disease. Urology is accounted for, BPH, all of our urologic cancers are accounted for. And we know just by sheer population statistics, something like prostate cancer, if you live over a certain age, high likelihood you're going to get it. And so in these low-income countries, as healthcare has gotten better, as people have begun to live longer, those conditions in urology that affect the aging population have become more and more relevant. In terms of I don't know. The other part of it, I think, in urology that is very interesting is just the workforce element. Maybe I'm getting too far away from the question you asked.
No, not at all.
But, I think in the United States, according to the AUA census last year, which I was just looking at for a related but unrelated reason, I think there's about 4 urologists per 100,000 people in the United States. I think in the UK, there's something like 2 or 2.5. Statistics in sub-Saharan Africa quote something like 0.025 urologists per 100,000 people. I'm very familiar with, through the work that I do, with the Rwanda Urological Association. About 16 million people live in Rwanda. There are currently 17 practicing urologists in the country, and there are 19 urology residents in training, which is great. But certainly
Double the workforce.
Doubling the workforce, 40 urologists for 16 million people, though, is still pretty far away from enough urologists to take care of the burden of the diseases.
And would you say, we're both reconstructive urologists. Would you say that reconstructive urologists are maybe uniquely trained to deal with the burden of disease abroad? Or is it just that you and I are reconstructive urologists, so we know about reconstructive urologists abroad and the whole disease, the whole spectrum of urologic disease is in need?
Yeah, I think that's an interesting question because it gets to the point of we don't really know what most of the numbers are in most places. Mm-hmm. Anecdotally, talking with partners in other countries, reading the literature that's out there, congenital issues, stones, and reconstructive urology tend to be the clinical conditions that providers see with most frequency. Mm-hmm. Endourology or stone disease is, a huge part of urology care in low and middle income countries, very dependent on surgical equipment to do endourology. So lots of countries, despite having the skill set, are still doing open surgery for stone disease. Reconstructive urologists, I think, are uniquely positioned to do international work because we don't require that much stuff to get the job done. We're still trained in being open surgeons. We don't require that much advanced technology. So I think from a technical skill set, very well positioned to do international work. And then from a need perspective, low and middle income countries, at least that I've engaged with, have tended to express a high need for reconstruction because it is a nuanced field that does require some surgical mentorship. And, people living in low middle income countries read many of the same guidelines that we read. I mean, they read the European guidelines, they read the American guidelines. Some countries have worked on developing their own guidelines, but when you read in a guideline, a urethroplasty should be considered only if there's a person who's trained to do urethroplasty. That becomes a challenge when you have nearly an entire continent with nobody who has necessarily met the high-income country bar for being trained to do a urethroplasty. So, if they can just get a few people in sub-Saharan Africa that kind of meet the bill on being able to do urethroplasty, you've allowed people to have access to care that's not that, hard to do.
No, not at all.
I mean, I feel silly saying that, but, we take for granted that we see these things throughout our training. We see them throughout residency. You see them throughout medical school. And so when you go to learn a urethroplasty, it's not, you have all of this experience that you're bringing with you. But if you are living in a country where there's nobody doing urethroplasties, you haven't seen it in medical school, you haven't seen it in residency, it's really hard to come forward and say, well, I'm going to start doing this. And sometimes it only takes seeing a few to, feel like you can start to do them. And so I think reconstructive urology is well positioned for this type of work. Pediatric urology is very similar. And I'm talking about bread and butter when I say well positioned. I'm talking about bread and butter kind of urethroplasty, incontinence procedures. But I'm not talking necessarily about neurogenic bladder, complex reconstruction. That requires a lot more patient buy-in, physician buy-in, longitudinal follow-up, et cetera.
Yeah. Maybe not an Indiana pouch, but like a reimplant when needed.
Yeah, exactly.
Mm-hmm.
And I will say, the need for cancer surgeons and cancer-related programs is there, but it's a challenge compared to reconstructive urology. When you have a urethral stricture, when you have a pelvic fracture, urethral injury, when you have prostate cancer that's becoming metastatic.
Yeah, and I mean, like being able to provide, neoadjuvant or adjuvant therapy, being able to like have access to radiation. I think that it's not all like, can we do an open prostatectomy or not? Like, you want to talk about guidelines, like, there's a different guideline for locally advanced versus, advanced prostate cancer versus early detection. I think that trying to provide what we would consider standard of care oncologic care, I'm sure is got to be more difficult than you have a problem, we have a surgery that will fix it with a relatively high success rate, and then you're good, and we should monitor you in some form or fashion. But yeah, I mean, I can see that the it's just not like a lower bar for what we do, but a lower bar to be able to provide standard of care. I think maybe it's a good way to say it.
Yeah, I think it's a great way of saying it. And again, standard of care somewhere else is not necessarily the same as standard of care in high-income countries. But even to put together the resources to make a functional prostate cancer surgery program is a lot. And it's not outside of the possibility for lots of low and middle income countries, but there's got to be a lot of interest and investment in infrastructure. And that extends beyond, the altruistic surgeon that wants to come and try and do good and teach prostatectomy.
Yeah, absolutely. Getting into, we've talked a little bit about kind of the big picture as far as like specific programs. I'm sure most people listening to this are aware of them, but could you kind of go over, what is currently available as far as, standardized, consistent programs involving urologists in international care and service?
Yeah, I mean, I'm no expert on everything that's out there. I just know some of the stuff that's out there. I think kind of globally speaking, there's it's an anesthesia book on global anesthesia, the role of anesthesiologists in global anesthesia. And there's like a chapter in there that is written by, I think he's a cardiac surgeon. And he sort of explains that in global surgery, there are kind of three categories of programs. There's clinical programs, there's relief programs, and there's, I think he calls it, developmental programs. And so a clinical program is, a program that you would think of like unmet, for example, where there are established partnerships with an organization being IVU Med and international surgeons that may or may not be through an academic institution on their end who have requested surgeons, come and help teach and also help do surgeries. So IVU Med is obviously a huge program and the biggest program in the United States, without a doubt, for delivering international urology care and international urology teaching. Sort of that relief program are the types of programs you think of that pop up in response to a major event. So I know we've had people in the recon world talk about the response programs in Ukraine, going and doing work in response to some sort of crisis, major disaster, some of what the military does, for example. And then there's developmental programs, which there are probably more urology programs than I know about that exist out there that fall into this, under this category. But they're programs that have sort of a established partnership, usually between academic institutions or between an academic institution and a Ministry of Health. And there's sort of a charter, there's a goal, there's a long-term longitudinal program design with, as I view it, the end game being capacity building and the end game being departure of the high-income country and sort of leaving a strong program behind that can function on its own. And so in urology, I think we have IVU, which is kind of a combination between clinical and sort of the developmental program model. There are other programs outside the United States like UroLink, which is the British Urology Association's global surgery arm. They're also similarly a little bit of a developmental, somewhat clinical, but really focused on education and academic partnerships and exchange. And then other countries have other programs that they run. But here in the United States, to date, IVU Med has been the biggest for urology across the board. ABCDE is a program that is a bladder extra-fee program that I believe was started on Hopkins that does extra-fee capacity building in several low-middle income countries. That has been very impactful. Those are the two major ones, honestly, that I can think of.
Yeah. No, it's interesting to hear it broken down like that. I had always thought about programs as like clinical or capacity building, like, and I've got it, written down here somewhere here as a question for you, like the balance between doing surgeries and creating kind of a sustainable system. I recently went to Ukraine with the group out of Cleveland Clinic case and now Ohio State that is going to Ukraine. And I was thinking of it more of a clinical program and now think of it more like a relief program. I think one of the differences being that like there was a huge component of it which was almost like a goodwill mission that I didn't expect. I expected more of a clinical program and got there and there was so much talk about like the Ukrainian people feeling abandoned, and having a Western program come was like uplifting for the group, which was really cool. But I should have talked to you beforehand because I think it fits really nicely into that relief category that I didn't quite know how to name for it. But you specifically, your work in capacity building has been, so even in your fellowship and now so young in practice has been like super inspiring. I was wondering if you could tell me a little bit about GU impacts.
Yeah, sure. I would love to. Very cool that you were in Ukraine, though. I didn't know that.
Yeah. Well, sorry, I thought I told you. No, I went a couple weeks ago and it was, like I said, I wish I would have talked to you beforehand to understand the categorization better, because I was expecting clinical and the relief portion of it was just, I got really teary at the end of it. Like I did not expect it to, I thought expected to go on volunteer and didn't expect it to kind of hit as hard as it did.
It's huge work. And, there's a place in my mind for all these things. And there are people that, are drawn to all of these types of things. And I don't think it's anyone's individual job in the world of global health or in the world of global surgery to sort of police what or how things should happen. I do think that in the world of capacity building programs, there are rules, there is structure, there are sort of tenets that should be followed when trying to build sustainable change. But I think sort of the perspective of it's okay to do these various types of care delivery programs is important, for lack of a better word.
Yeah, I mean, I think one thing that I thought about while kind of thinking about this episode and this interview was like the different places for each and the roles for each. And I think that there are some places, you're right, are like maybe not yet set up to start capacity building. Like to me, of those three things, like capacity building seems like kind of the most evolved form of it. Like, okay, we are now ready to teach to be able to extract ourselves from the environment. But I think that like some places just aren't ready for that and need help and need cases done. But I do think that capacity building is like should be the goal everywhere. But there are some places where they're just, you need to get the cases done.
Yeah. And, one thing that one of my colleagues in Cambodia told me recently was he said, time changes everything. And that was in the context of sort of how far the Cambodian surgeons have come and where they are now compared to when I lived there 13 years ago. I mean, it is remarkable. The hospitals are unrecognizable. The care that's delivered is unrecognizable. And it's not because necessarily there was a huge capacity building program. It was just, infrastructure and government commitment to developing their healthcare system and positioning them to be in a place where now you can do the next level of subspecialty training, care delivery, et cetera. But yeah, it's just interesting. It's interesting to watch a place change so much. And, kind of segues to the work that I've done and our program, GU Impacts, in that, and I'll tell you a little bit more about the program in a moment, but I'm just going to give it a little bit of context, which is at the University of Utah, my mentor, Division Chief of Urology, Dr. Jeremy Myers, has been going to Rwanda with IVU Med for years. Maybe over the course of the last 15 years. I think he's been like 7 or 8 times, always with the same group of people. And there have been a handful of reconstructive urologists who have really committed independently with the help of IVU Med to going to Rwanda and providing these sort of clinical care delivery plus surgical education teaching programs while they're there. And, Hadley Wood, Frank Burks, Jeremy Myers are 3 of those people. And what's interesting is they really set up the vision for the work that we're now doing kind of all together, which is people in Rwanda, surgeons in Rwanda, didn't see a urethroplasty. They didn't know you could do a posterior urethroplasty or how to do it. And then Myers and Wood and Frank started coming and showing them. And they started to inspire some of the, at that time, medical students who then became residents, who then became faculty to say, oh, I want to learn how to do this. I want to become an expert in this. And so even though 10, 15 years ago, maybe Rwanda's infrastructure was not really where it is now to be pursuing, capacity building, fellowship development, et cetera, those clinical programs 15 years ago laid the groundwork for the future by inspiring people to be excited about subspecialty work in urology. So I always view sort of those relationships as the potential for being really important because they're inspiring. And I would never have known I wanted to be a reconstructive urologist if I didn't go to a residency where there was a reconstructive urologist.
Absolutely, yeah.
So anyways, kind of segueing back to GU Impacts. So GU Impacts is a program that we started at the University of Utah. It's based in the University of Utah Center for Global Surgery. It's a very long acronym.
It was a great acronym. I saw it originally and I was like, that is a phenomenal acronym. I was like, you need to do some, and you're doing a clinical trial through GERS, but I was like, Jane needs to do more clinical trials because this is a phenomenal acronym. It
really was a beautiful mind type of moment when I came up with it, but it stands for Global Urology Initiative and Multinational Partnership for Advancing Capacity and Training in Surgery. If you're not a urologist, unfortunately, like my family members, they asked me why I named it GU Impacts. But hopeful that, urologists pick up on the GU part of it. So The vision in starting this program was to create a longitudinal program that delivers surgical education in subspecialty urology in low and middle income countries. And the model that we've implemented is partnering with the urologic associations in a handful, I can't even really say a handful so far, two low-income countries, one being Rwanda and one being Cambodia, and assembling a team of people that are interested in committing to a 5-year program for surgical education delivery. And it's like what I refer to as a needs-based program, meaning, in Cambodia, I went and did a needs assessment. I went to all your hospitals in the country that deliver urology care, met with their urologists, toured their operating rooms, figured out sort of anecdotally and a little bit with some numbers that are available what their greatest areas of educational need was in urology, which panned out to be...
Not just recon, but, it
no,
panned out to be recon.
I was actually prepared to, when I went there, to plan to start an endourology program. I mean, there's a tremendous amount of stone disease in Southeast Asia, like an outrageous amount of stone disease. And so I thought, low-income country, lots of stone disease. I bet I go and they say, hey, can you come and teach us how to do PCNL and assemble a team around that? And I showed up and I saw them do PCNLs and I was like, you could do a PCNL on me. I mean, they've gotten really great support from their hospital systems, from the ministry, in the big teaching hospitals. They do have equipment to do PCNLs and they're very well trained in endourology. They do things slightly differently, rely a lot more on X-ray than CAT scan, for example. But they were like, we don't really need help with this.
Now that shows commitment because, and I don't want to offend our endourologists. They're some of the colleagues that I'm most thankful for because I don't like to do stones. But for you to commit to a program where you were planning on, teaching people to do PCNLs, I think nothing shows more commitment than that.
Yeah. Yeah. But I mean, I was like, can you guys teach me how to do a PCNL,
Yeah.
So that was a really interesting experience, but, panned out reconstructive urology, female urology, pediatric urology, and then sort of this looming cancer, oncology. Urologic oncology is always sort of looming, as I alluded to before, in the low middle income country setting. And Rwanda did a similar thing, similar outcome, biggest need, reconstructive urology, female fistula disease, pediatric urology, and then again, sort of looming need for oncology. And so with that information, the model we came up with was, let's get dedicated teams of people who are fellowship trained. We'll start with reconstructive urology. It makes sense. Doesn't require that many resources. There's already a very strong presence of reconstructive urology interest in the IVU Med participation in the past, and let's start programs around recon. And so our Rwanda program, we have 6 fellowship trained reconstructive urologists who have committed to 5 years with the program. We have met with the Ministry of Health. We've met with workforce development in the Ministry of Health specifically. And the ultimate goal of the program is to help Rwanda create what will be the first locally led fellowship training program in reconstructive urology in East, South, and Central Africa. And it's an interesting model. So we have our 6 surgeons. Each one is committed to going once a year for 5 years, which equates to, 3 workshops per year. We do preoperative case presentations. We do clinics where we meet the patients. We do the surgeries where we're working in tandem always with attendings in Rwanda. We do postoperative follow-up. We keep clinical records of patients. I mean, they maintain clinical records of patients so that we can have follow-up conversations. But really, that's kind of the on-the-ground work. But really, what's come out of this program is a champion for reconstructive urology. And so sort of inspired by the work that those faculty members I mentioned before were doing with IVU Med in the past, one young Rwandan surgeon emerged and said, hey, I want to be the first reconstructive urologist in Rwanda. And so our program said, all right, let's work with the ministry. Let's figure out how we can do this. So his name is Dr. Théophile Ndayishimiye, and Dr. Theo, I'll call him for short, is now a very close friend and colleague. He would be in his third year of practice as an attending, and he got accepted to do a 1-year dedicated fellowship training program in reconstructive urology at Mansoura University in Egypt, which is a really great program. And through a grant that we got through the Center for Global Surgery and through monies given to him by the Ministry of Health of Rwanda, they have sent him to Mansoura to be the first formally fellowship-trained reconstructive urologist in East Africa. And when he comes back, the goal is for him to have the first dedicated subspecialty surgical practice in reconstructive urology in Rwanda, meaning he doesn't have to see, do TURPs and TURBTs and see recurrent UTIs and ball pain and all those things. He actually gets to be a reconstructive urologist in one of the public teaching hospitals. Most, not all, but most cases should be kind of funneled to him. He gets to have a direct line of communication, with the ministry about the burden of disease that he's seeing, because it's not going to be scattered around sort of the country or missed because maybe the patients are not being referred to appropriate places. And we're going to continue our program as he builds his first years of practice. And what is really appealing about this model is, you think about us recently graduating from fellowship. And, you went out to a place to be, one of 2 reconstructive urologists where there wasn't a reconstructive urologist working, right? But you knew that you had the mentorship of other high-volume surgeons doing complex surgery at your institution.
Absolutely. And an FP, an FPMRS trained, kind of mixed recon trained surgeon. Like we had good mentorship. I think what you're kind of getting to is I can't imagine being
the first person in basically a whole continent. Yeah. Granted, I will say that Dr. Kulkarni's current fellow in India is Dr. Emmanuel Oyibu, who is a surgeon from
He's Nigerian, right? Yeah.
And so he's finishing up soon. And when he goes back to Nigeria, he'll be the first sort of formally fellowship-trained reconstructive urologist in West Africa. I've, of course, introduced Theo and Emmanuel to each other, which is great. It makes me really happy. It actually kind of makes me feel almost like I told them, like the Makinich and
Jordan, yeah.
Exactly, Jordan of the East Coast, like East and West Coast. Granted, we're talking about one country and I'm talking about an entire continent, but that's sort of where it starts, right? You just need a handful of people that are passionate about this stuff.
Absolutely.
But the nice thing is that Theo knows that he has 6 external mentors that for the next 2 to 3 years after he gets back are going to be coming with some frequency. And if he has to I just talked to him today and he said, one thing I haven't done yet in my fellowship is a gracilis. And he was like, I know it's not hard. Jeremy Myers told me it's not that hard, but I've never done one. And I just feel like I want to do one. And I was like, you'll save one. When we come, when you're back, we'll do 1 or 2 with you and you'll feel good about it.
He'll have it, yeah.
Right, he'll feel good about it. But, from his perspective, to have 6 external mentors that he knows are coming on a recurring basis as he's building his practice is meaningful.
Huge. Yeah.
And from the government's perspective, to know that they have external mentorship for this whole new field that they're sort of offering for patients in their country is also a big deal. So that's sort of the model. The goal is to, kind of hand over reconstructive urology to Theo and probably 1 or 2 other people that want to follow a similar path of his. And the goal is that in 3 years or so, he'll take his first local fellow. And whether that is a surgeon from Rwanda or a surgeon from a neighboring country, that's yet to be determined. But that's sort of the big vision, is that Rwanda could become a hub for subspecialty teaching of urology subspecialty surgery for East, South, and Central Africa. And instead of, us having to assemble groups to go to Kenya and Tanzania and Malawi and all these places, we can just support this model of Theo taking on trainees or Theo plus taking on trainees, and have it be a program that can run without high income country presence.
Yeah, absolutely. Especially with, like you said, with the Ministry of Health kind of on board with him creating that practice, not having to see, anything but the recon that he hopes to make his whole practice, just an amplifier for him being able to teach.
Right.
Mm-hmm.
Yeah. And be able to know what the burden of disease is and be able to sort of, develop almost like a center of excellence where you can request the resources that you need. It's very hard when there's limited OR time and there's a case mix and there's, 400 patients that need a TURP on backlog, and there's maybe 20 people that you know of that need a urethroplasty, and a TURP's going to take an hour, but a urethroplasty is going to take 4. And a urethroplasty might need, 12 sutures. That's a very small number of sutures. Like, I don't know how many 12 suture urethroplasties we could do, but you know what I'm saying? That's a lot of suture to a country that's got a tight inventory on suture. If it's all happening in one place, it gives that place the ability to say, hey, this is how many urethroplasties are on the docket. This is what we're using our OR time for. There's 130 patients a year with this pathology. If we're treating all of them, and we're using 20 PDS suture equivalents, per week, you can actually have the inventory to do the surgeries, which sort of brings it all back to the point of the type of capacity building work that I'm passionate about relies on being in countries where there's already infrastructure. And there's an investment in infrastructure.
Yeah, absolutely. It does make it, it seems reliant on a local champion though, right? Like I'm sure your Cambodian group has to have a similar person, right?
Yeah. So interestingly, Cambodia has not had a lot of exposure to, clinical type or mission type or even, care delivery programs from the United States. They have partnerships with France because of their kind of history, but there isn't a lot of exposure to reconstructive urology. So I sort of view what we're working towards in Cambodia as kind of those first 5 years of Jeremy
time.
Myers and Hadley and Frank Burks going and inspiring people. And so, I surveyed their residents there when I went there last, and there were a handful of people that said they wanted to be subspecialists. I mean, there are no real subspecialists there yet either. There were a couple of people that said first-year interns that said they wanted to be reconstructive urologists. But, in the survey, they said that they had not done or seen any reconstructive urology yet. So I kind of view us as being behind, several years behind in terms of first doing the inspiring part and then doing the sort of capacity building part, but maybe having the experience to kind of roll them in together a little bit more.
Earlier on the curve, not behind.
Yeah, exactly. Maybe. Yeah. I don't know. I mean, a lot of this is trial by fire. I think you really need good partners. That's kind of the key to all of this. And so, yeah, I mean, I'm super excited about how things are going in Rwanda and excited about how things are developing in Cambodia. Really grateful, I'll say, to IVU Med. They've been really supportive in our program building in Rwanda, and we've really partnered with them in terms of, our licensing and coordination and administrative stuff. And so that's been really great over the last couple of years. And just really excited for the possibility that there might be a reconstructive urology fellowship program in a couple of years in sub-Saharan Africa.
Yeah, pretty cool.
I hope.
Yeah.
I mean, I'll be pretty excited if there's a avenue for applying for GERS accreditation for a sub-Saharan based.
That would be huge.
Recon program.
It sounds like, the right people are there to make it happen, like the folks in IVU Med are all involved with GERS, and, it seems like a program that would have the connections if he's, kind of hitting the metrics that they're looking for. And it would be huge, right? Like it would be an amplifier to an entire continent.
Right. I mean, you look at Kulkarni instance, he's revolutionized what it is to do reconstructive urology in India. I mean, in a country, I don't know how many billion people are in India right now these days. Is it one point something or 2 billion? I don't actually know how many people are in India. Do you?
I know I should know because I was there last year and I should know off the top of my head, but I don't. But I can tell you that it is certainly a lot.
Yeah. It's a lot of people.
Yeah.
And really achieve that by sort of becoming a highly skilled reconstructive urologist who set up a center of excellence.
Mm-hmm. Yeah, I mean, that's one thing that I was there for the AUA exchange with Niels Johnson, who was one of my mentors from residency. And we were at their annual meeting. And at one point we're watching like the videos, not from the Koch Institute, but from like other urologists. And we were like, oh my God, like these guys know perineal surgery. Like they really know perineal surgery. And it is not a like Koch only institute phenomenon. But I mean, really it's a ripple effect from kind of his exposure for the country, right?
Yeah, it's 1.45 billion.
Thank you for looking it up.
I thought it was somewhere in between 1 and 2, but not
pretty
sure.
good.
Yeah.
So looking ahead, where do you see global urology heading in the next decade? And talk about it in whatever capacity you want. GU impacts in 100,000 foot view or whatever number it's supposed to be, 30,000 foot view. Where do you see global urology heading?
Well, like I kind of said before, is time is a good thing. So I think that some of these countries where there are international volunteer presence, are going to naturally over the next 10 years have improvements in their own healthcare infrastructure. So, I think there will always be countries that are just not even doing urology yet or doing urology on a super low level. But I think over the next 10 years, probably more and more countries will be more and more capable of delivering, relative to their resource availability, relatively good general urology care. And I really think that the future of global urology is in subspecialty support. I sort of alluded to it before, but subspecialization and developing centers of excellence, I think in the low middle income country setting is really impactful from a workflow perspective. And so, I think one of our shortcomings here in the United States, of course, is that we are so siloed, right? I saw someone the other day who needs testosterone, but he's a prostate cancer survivor and he was just re-radiated and I just did a pelvic exent on him. And, so you should see your oncologist to talk about if you can get testosterone, and then you should go see our men's health group to see if to see about getting the testosterone, and then I'll see you for your, 3-month ultrasound and labs, which always feels in some ways a little silly, but of course it's important. But I think that in low middle income country settings, that sort of siloing kind of helps organize care. And it helps organize health systems, and it helps organize patients, and it helps organize inventory, and it helps organize referrals. And especially in kind of the early days of subspecialization in many of these countries, I think that's really important.
Mm-hmm. Yeah, it streamlines care.
Right. I think to be someone that dabbles in this and dabbles in that, makes it very unclear what resources are needed, how many patients there are. And as you're building more robust urology programs, that information is really important. So I think subspecialty care is probably going to become more relevant and more attention is going to be put towards that in urology. Something that I, of course, would love to see is us figuring out how to sustainably build surgical oncology programs in urology in low middle income countries. I mean, I'm not a surgical oncologist, obviously, but, it's a challenge. And, patients and providers do want to be able to diagnose people early and treat them, or at least offer them treatment. And unfortunately, I don't think there's a lot of financial resources out there to work on building programs like that. But I'm hopeful that over the next 10 years, we can figure out how to screen for bladder cancer in low middle income countries that probably have much higher rates than we do in the United States, and help them figure out how to manage these patients before they're metastatic and they're dying of young ages.
Yeah, I mean, I think, and you've alluded to it, and I'm sure, and I mean, you talked about record keeping. I'm sure you're keeping kind of like not only patient records, but probably some epidemiologic records too, to understand, where the need is and where it's going to be able to create those centers.
Yeah, and that's something I've spoken to some people in the urology world who are really involved historically in global urology work, is getting programs together in a handful of low middle income countries to truly assess the disease burden. And I think from what I gather, Urology Care Foundation is motivated to try and contribute to that knowledge.
That would be huge.
And so I'd be really excited to see, what comes of that. So, I think that that's probably where things are headed. I mean, I would love for AUA or GERS or, one of our subspecialty organizations to kind of have a formal global surgery arm. I think urologists should be at the table with other surgeons in the discussion of funds being contributed to global surgery causes. I mean, as years go on.
No, but I mean, that's huge for the Urology Care Foundation to get involved. I mean, it's on a macro level, talking what you've talked about on a micro level, which is like you have to understand what you're getting into to be able to like know how to capacity build, right?
Yeah. Yeah. And, you look at like the American College of Surgery, for example, and they have HOPE. They have, which we used to be called Operation Giving Back. And now it's called ACS HOPE. And, that's the American College of Surgery's global surgery arm. If you are a surgeon in the American College of Surgery and you're interested in doing global surgery work, like you can get involved through HOPE.
ACS HOPE, and they have I think they have like a global certificate too that they give out, but it's a year-long program specifically designed for capacity building. If I'm not incorrect, yeah.
Yeah. I actually just started serving on their subcommittee for
Awesome.
for education in their global engagement committee for education, and so I'll be learning more about that certificate program. But they're super excited to have a urologist involved. I mean, Catherine DeVries for a long time has been involved with American College of Surgery as a urologist, but I think that I think my hope is that as people get more excited about building partnerships and capacity building programs, that our own professional organizations get excited about it.
Yeah. I mean, I think that similar to the, three surgeons being the source of inspiration, it makes sense. I can see the evolution, and it makes sense to me of like, you've got three surgeons. Now you've got a capacity building program, then you've got a society that gets behind it, right?
Yeah.
And if the Urology Care Foundation is potentially interested in some of that work, then that's a canary in a coal mine to me, I think, or maybe like whatever the positive version of a canary, bellwether. Yeah.
Yeah. I mean, I think something that I'd love to see sort of in partnership with AUA or European Urologic Association in my lifetime is sort of developing guidelines that are low-income country specific.
Oh, wow.
And, I've talked with colleagues before from various countries, and they said, I alluded to it earlier, we read your guidelines, but like we can't do a lot of it. So what are we supposed to do when we can't do it? And, several countries have developed their own guidelines, or they're developing their own guidelines. And I just think, it would be so amazing if we could figure out a way to put a couple of leaders in urology from low middle income countries or upper middle income countries too together and say, these are the realistic alternatives if you don't have a cysto available. If you don't have PSA screening is not as easy to do. What is a realistic protocol that you could do to surveil somebody after prostate cancer diagnosis? What is realistically active surveillance in a low middle income country setting where they can't do alternating MRIs and biopsies? What are their antibiotic recommendations? How do they go about coming up with their own perioperative urology antibiotic guidelines? I mean, we rely on those things, but those are based on our antibiograms.
Yeah. Yeah, I mean, that's and hopefully that would be pretty attainable, right? Like, although again, to your point, the AUA can't just say, all right, we're going to like add a section to the AUA stricture guidelines. Like, you have to understand what is feasible and what resources are available. And, there's so much understanding that probably goes into it. I was just about to say that's such low hanging fruit, like add a section of the guidelines. And that's the problem, right? Is that it can't be just that. It's got to be with understanding of what capacity exists.
Yeah, what capacity exists, what resources exist, what human resources exist. If radiation abilities are not as at the standard that ours are, is radiation equivalent to surgery? And all this kind of gets me to my point an extra point of, I'm really passionate about research driven by low-income country leaders to address context-specific research problems or clinical problems. And, it's hard. We, again, take for granted the education we get and exposure we get to research and doing studies and institutional support, et cetera. And that doesn't exist in a lot of countries. And so I think for people that are interested in going beyond, a workshop or a clinical stint in a country, oftentimes the biggest way you can contribute is helping them push a research project forward.
Yeah. They in a lot of cases probably don't even have that mentorship to be, we teach our medical students, like, think about a problem that you're having, like, make that a research project. And they probably don't even have that, like, the kernel of, you should be thinking about your daily life and what questions you want to answer.
Yeah, there's a lot of reasons why not. There's a lot less time. There's a lot more patience. There are a lot more barriers to doing research, but something that we can do as high-income country providers, especially ones that are already have relationships in other countries, is offer to read their paper. Offer to talk about a research idea that they have and think through what could be a realistic way to do that project. And even if it's a project that's been done over and over again in the high-income country setting, like, you might have a totally different outcome in a low-income country setting. And that's important. We have a paper I just worked on with Dr. Ende Ishmael about posterior urethroplasty in pelvic fracture urethral injury patients, and looked at urine cultures, pre and post-operatively. And, we don't put people routinely on antibiotics, after urethroplasty, because there has kind of been no correlation between antibiosis and, stricture outcomes. But we saw a relationship between positive cultures and stricture recurrence risk. And maybe that's different. Maybe patients should be on antibiotics. I don't know. I can't answer that question with the data that we have, but it does make you question in places where people don't have clean water, where people don't have, access to the types of showers and resources that we have. Like, do they need a different protocol?
Yeah, and I remember talking about this in pediatric urology, and I hope I don't butcher the evidence, but you talk about things like communicable diseases and circumcision, and like the difference between low and middle income countries that may not have access to the first world hygiene practices that we do, and how that potentially changes the risk of communicable disease as it relates to circumcision. That those relationships must exist in every single, disease state that urologists treat and that everybody treats. So, it seems like that you'd have to have relatively region-specific research for all these questions.
Yeah, I think so. It's something that I just encourage anybody who's doing global surgery work in urology to think about, which is help support a research project, because you can help people move the needle a lot if they have an understanding of the problems, outcomes, things that we take for granted here in their own context.
Yeah, absolutely. That kind of brings me to my last question, and you've answered it a little bit. What advice would you give to someone who's interested in getting involved in global surgery and global urology? I mean, you've given us tons of excellent advice already. So if you're tapped, let me know. But what you've got a medical student or a resident that says, Dr. Kurtzman, I really want to get involved, but I can't go on a service trip. What do you tell them?
Yeah, I think that first and foremost, probably need to learn something about kind of the tenets of global health, global surgery work. And, there are various universities that have programs, not necessarily full MPHs, but certificate programs. You sort of alluded to the ACS program. I'm pretty sure UCSF has a program that they run that I think might be open to people outside of UCF to enroll in. Here at the University of Utah, we have a program for medical students to do sort of a global health track. But I think that first and foremost, you kind of have to learn about systems, the history of global health, what it means, how it's evolved, et cetera. And there are formal ways to do that. So to a student or to a resident, I would say, let's start there. I mean, our Center for Global Surgery here at the U has an asynchronous learning course that they've developed for residents who are engaging in projects with the Center for Global Surgery or fellows that come through the Center for Global Surgery, which takes you through a course on what is global health, what is global surgery. So I think that's important. I think for people that want to get involved or want to start their own program, the best advice I think I got was look for programs that are already functioning and try and kind of connect yourself to them.
Yeah.
Learn about them, learn about how they function and what they do. I think what I said earlier is also really important, which is that I do believe that global surgery work comes in kind of all different formats. And I'm particularly passionate about long-term capacity building. Not everyone has to be passionate about it. So if you're passionate about, some other form of global surgery involvement, pursue it, but just make sure that you're doing it in a way that's equitable, in a way that's legal, in a way that respects the culture and respects the rules and regulations of the countries that you're working with. And always think about, is there a way for this to be an exchange rather than a one-way relationship?
Yeah, absolutely.
I think that those are the really important tenets of international work, that whether you're going once for a week somewhere or you're going every year to a different place, just ask yourself those questions.
Mm-hmm. Yeah, I love that. Well, thank you.
And I didn't make those up. Those are I kind of summarized some of the basic tenets of international work.
Yeah, we will not send you a certificate if you finish the episode.
Yeah, I did not make up those things, but I do think it's super important to be aware. And I guess one last thing I'll say, and this is probably the anthropology major in me, is that just be really aware of cultural differences. And you can learn a lot from other countries, both in the way they deliver medical care, the way that people interact with life and death conversations. And it's not your job. It's not our job to change people's culture. So that's the anthropologist in me.
Well, I love it. I mean, that I'm sure is probably hugely informs the work that you do.
Yeah, I don't know. Hopefully. In some way, I don't know. I mean, you think about, right, we're early career urologists, but you think about the things you've done in your life that have gotten us to these points. And it's funny when you look back and everything sort of ties together in a way that just doesn't really make any sense, but kind of all makes sense at the same time.
It didn't make sense. It didn't make sense as it was happening, but every decision that you make is informed by ones that you've made before, right? Thank you so much again for joining me on BackTable Urology, Dr. Kurtzman. Your work internationally has really been inspiring, and I look forward to seeing it grow and evolve, as our early careers kind of do the same.
Well, thanks for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.